Welcome to the education module, Psychosis and Dementia. In this module and throughout this series, the term persons living with dementia will be used to emphasize that dementia is a diagnosis and does not define the individual. Dementia is a highly stigmatized disease process. The term person living with dementia is used to promote positive language and a more person-centered approach. The purpose of this module is to discuss the neuropsychiatric syndrome of psychosis. The National Institutes of Health and National Institute of Mental Health describe psychosis in the following way. The word psychosis is used to describe conditions that affect the mind, where there has been some loss of contact with reality. When someone becomes ill in this way, it is called a psychotic episode. During a period of psychosis, a person's thoughts and perceptions are disturbed, and the individual may have difficulty understanding what is real and what is not. A more basic definition of psychosis is a loss of contact with reality. Psychosis may be an indicator of delirium associated with an underlying physical illness or a serious and persistent mental health condition such as schizophrenia. Psychosis is also a very common feature in major neurocognitive disorders. Dementia is a major neurocognitive disorder. Approximately 40% of persons living with Alzheimer's dementia experience psychosis sometime in their lifetime of their diagnosis. Persons with dementia and psychosis may actually receive an inaccurate diagnosis of schizophrenia. So what about hallucinations and delusions? In one study, 10% of adults age 85 and over without dementia reported psychotic symptoms. For older adults with dementia, the psychotic symptoms can range from 18% for delusions and 36% for hallucinations. Symptoms of psychosis can include hallucinations or delusions. Delusions and hallucinations often present together. Delusions are fixed, false beliefs. An example of a delusion is believing that radio waves can control your thoughts. Delusions are more common than hallucinations. Delusions tend to occur earlier, and hallucinations occur in later stages of dementia. For persons with dementia, there are poorer outcomes with combined delusions and hallucinations than if they just had delusions by themselves or hallucinations by themselves. Hallucinations can be tactile, auditory, gustatory, olfactory, or visual. One example of an auditory hallucination is hearing voices, while visual hallucinations involve seeing objects that are not really there in reality. A perceived smell is olfactory, perceived taste is gustatory, and perceived sensation, such as bugs crawling all over your skin, is a tactile hallucination. Specific types of hallucinations and delusions are neuropsychiatric syndromes often associated with certain types of dementia. If you look on this slide and see the table, the different types of dementia are listed along the left. In persons with Alzheimer's disease, 30 to 61% of psychosis can actually be genetic mutations. Psychosis is common in Alzheimer's dementia, less common in vascular dementia, and typical in Lewy body and Parkinson's dementia. Compared with vascular dementia, Combined hallucinations and delusions are more common with Alzheimer's and are associated with poorer outcomes. Delusions are more common than hallucinations for a person with a diagnosis of Alzheimer's. Paranoid delusions are common, often associated with a theft such as someone stole my purse or them thinking someone is trying to kill me. Other delusions include misidentification, such as mistaking a spouse for a child. Paranoid delusions are common with Parkinson's dementia. However, dementia is not always present with the delusion for persons living with Parkinson's disease. Hallucinations also have a stronger association with atrophy of the prefrontal gray matter, cortical Lewy bodies, parietal and occipital regions, and to a lesser degree with APOE4 alleles. These are different things in our brain. Visual hallucinations are very common with the diagnosis of Lewy body. These hallucinations are associated with actually the front and interior parts of our brains. So you know your loved one best. Any symptoms that are out of the ordinary could indicate an underlying condition. The first step in recognizing dementia-related psychosis is to consider potential triggers or environmental cause. Is your loved one hungry or tired? Are there any changes that have happened in caregivers or changes in routine? These can actually be a potential cause of psychotic symptoms. Urinary tract infections, heart failure, elevated blood sugars, or any other type of infection can cause these, as well as progression of chronic illness. They could be the underlying causes for these symptoms. Constipation is often overlooked. And then delirium is the first priority and considered a medical emergency. Delirium is the terminology for psychotic symptoms due to some kind of physical cause. It must be addressed immediately by a healthcare professional. Depression may also contribute to psychosis. Hallucinations and delusions may indicate an urgent physical or mental health condition. Your healthcare provider will perform a careful assessment of these factors. Once physical and mental health conditions are eliminated as a cause of the psychosis, the symptom may be determined to be related to dementia as a disease progressing. If your loved one experiences hallucinations or delusions, do not argue. Repeated reminders or continued what we call reality orientation often worsens symptoms. When the underlying cause is treated by your healthcare provider, the psychosis typically resolves and your loved one will likely not even remember the episode. When all underlying causes are ruled out, psychosis may be the result of dementia progression. Caregivers have most control over the environment. Promote a consistent routine and calm environment. It is common for your loved one to look for deceased relatives or believe that a stranger is their spouse or relative. A safe approach is to remain neutral and try distraction. Your loved one may accuse you of infidelity or theft. Do not take any negative responses personally. We know this is easier said than done. Try to remember that the hallucinations and delusions are not your fault or the fault of your loved one. Your loved one has dementia, and once the disease is talking, it is the disease, not your loved one. Remember that dementia is a disease of the brain that progresses every day. Safety is the most important concern. Call 911 911 if an unsafe situation develops. Person-centered plans focus on the person's goals, values, cultural identity, and the specific diagnosis that they have related to the psychosis. About 40% of persons with dementia do not experience emotional distress with hallucinations and delusions and respond well to non-pharmacologic interventions. Non-pharmacologic interventions should be considered before medications. Non-pharmacologic interventions are those that do not involve drugs or medications of any type, including oral, over-the-counter, and herbal remedies, and are psychosocial, spiritual in nature. Agitation, aggression, disruption, shadowing, depression, and repetitive behaviors can be improved with the use of non-pharmacologic interventions. Treatment and management plans must be tailored to the syndrome of psychosis. And then what type of dementia have they been diagnosed with? It is important to identify which non-pharm interventions were effective in treating their psychosis in the past, if they had it. Pharmacologic treatment with antipsychotic medications should be used very cautiously because antipsychotic medications carry what we call a black box warning for increase of death. Psychosis-related dementia can be distressing to the person living with dementia and caregivers. The symptoms of psychosis are often unpredictable and require close monitoring. One symptom may resolve and a new symptom may develop. More research is needed for biomarkers and early identification of psychosis. Considering symptom cluster for syndromes of specific dementia is often very useful in optimal treatment, which is all of our goals in care of the person living with dementia. Psychosis-related dementia is distressing. The symptoms of psychosis are unpredictable and require close monitoring. Caregivers who want to know more about the neuropsychiatric syndromes of dementia are encouraged to participate in all the modules for this Dementia and Neuropsychiatric Syndrome series. Thank you so much.